Okay, hi everyone. So welcome to the second video on the Ophthalmology Series. This lecture will be on red eye. Just for a bit of information on Bite Medicine, Bite Med offers a free editable textbook, over 1,500 SBAs and cases, along with free and premium webinars. So feel free to subscribe to the premium version if interested. Okay, I think we are waiting on something. Just give me a second. Okay. So in terms of the objectives, today we're going to go through the red eye differentials, sight-threatening versus non-sight threatening. The sight-threatening conditions will be highlighted in red, and then non-sight-threatening conditions will just be written in black. And the red flag scenario symptoms, as well as case scenarios, which will be dotted throughout. Okay, so we'll start with a case-based scenario. You are an ophthalmology registrar on call, and your first patient is an 8-year-old boy who's brought in by his mother. The child presents with bilateral red eyes. There is no associated pain, itchiness, photophobia, or visual loss, and there is no history of trauma. On examination, there is diffuse redness of both eyes with some lid swelling and yellow discharge. So take a moment to think about what the condition might be. Feel free to answer in the Q&A section as well. Okay, so it's conjunctivitis, bacterial conjunctivitis in this case. The common organisms for bacterial conjunctivitis involve staph, strep, pneumococcus, and Haemophilus. The infection usually starts on one eye and then spreads to the other, and the discharge is purulent, and that's what allows bacterial conjunctivitis to be differentiated from viral and allergic. There might be some irritation in the eye, but it's not usually painful. And in terms of management, the advice mainly consists of self-care and good hygiene methods to limit the spread of infection, and it should resolve by itself within a week. If these measures don't resolve it within a week, or if the patient is wanting quicker symptom relief, then you could give topical antibiotics such as chloramphenicol 0.5% eye drops, and that should help speed up the process. Okay, next is viral conjunctivitis. This is the most common type of conjunctivitis, and usually you may see outbreaks in environments such as schools where self-care and hygiene methods are less utilized. The conjunctival layer involves the bulbar conjunctiva, which is on the eyeball itself, and then you also have the palpebral conjunctiva, which is on the inner aspect of the eyelid. In viral conjunctivitis, the palpebral conjunctiva may be affected, and that's usually seen with the presence of the follicles that you can see here. The discharge is commonly watery, and there may be swelling of the eyelids along with preauricular lymphadenopathy, so lymph nodes here may be swollen. Management is similar to bacterial in terms of self-care and hygiene. However, antibiotics are not recommended. So you can give advice such as avoiding sharing towels, cool compress for relief, cleaning the eyes, etc. But you wouldn't use medication for viral conjunctivitis. Within 1 to 2 weeks, it should resolve itself. Okay. Next is allergic conjunctivitis, and this is the kind of non-contagious, non-infective form of conjunctivitis. And usually this is caused by things like hay fever or seasonal allergic conjunctivitis, which is an IgE-mediated reaction to airborne allergens. Usually it's pollen, and they interact with IgE-primed mast cells on the conjunctiva. That leads to mast cell degranulation and releases histamines, and that's responsible for the acute phase response. In the late phase, you have release and synthesis of prostaglandins and leukotrienes, and that amplifies the kind of fluidy processes such as conjunctival hyperemia, edema, increased vascular permeability. You can have discharge from the goblet cells, which release mucin, and also inflammatory cell infiltration. The itchiness, so pruritus, is the cardinal symptom of allergic conjunctivitis. Here on the eye, you can see the kind of swelling of the conjunctiva, and that's known as chemosis. And you may also get that kind of gritty foreign body sensation. In terms of management involves mainly avoiding the allergens, advising not to rub the eyes because that may irritate it further. You can use artificial tears and cool compresses for symptom relief. Topical antihistamines and mast cell stabilizers can also be used if it's long-standing or if you've tried the conservative methods and it's not been successful. Okay, so a second case-based scenario. A 55-year-old woman attends ED overnight. She complains of several painful and severely painful and red left eye. The pain is worse on eye movements. On examination, her visual acuity in the left eye is 6 out of 9 and 6 out of 6 in the right eye. Her pupils are equal and reactive with no RAPD. Her cornea looks clear, however, she has a deeply injected left eye. So if you just take a look at this picture, you may also use the presentation on her cheeks as a clue as to what she may be presenting with. Okay, so take a moment to think about it. So she is presenting with scleritis. Scleritis is a sight-threatening condition and is due to an immune complex-dependent microangiopathy, and treatment requires anti-inflammatory medications with or without immunosuppression. In the primary care setting, this would require an urgent ophthalmology referral within 24 hours. A systemic cause should ideally be looked for in cases of scleritis because it's associated with collagen vascular disease in almost 50% of cases. The most common is rheumatoid arthritis, but you can also see it in Wegener's granulomatosis, polyarteritis nodosa, and SLE, which was what was shown in the previous slide. So that classic malar rash, which is associated with SLE. So in the case of scleritis, it's advised that rheumatology involvement is started as early as you can if you are suspecting another underlying cause. The onset is typically gradual and it can range from days to weeks, and it's usually accompanied by deep, severe eye pain. There might be tenderness of the globe, and there may also be pain on movement of the eye. A bluish tinge is often seen, like you can see there, on scleritis, along with scleroedema. In terms of management, the first line for mild to moderate scleritis is an oral NSAID. Topical steroids might be used to reduce ocular inflammation, but treatment is generally systemic in severe cases, and this would ideally be started by a specialist because of the side effects associated with systemic steroids and immunosuppression, etc. Okay, and then episcleritis, which is also associated with connective tissue diseases. However, it's less commonly associated. Episcleritis is associated with IBD as well, such as Crohn's and UC. The onset for episcleritis is sudden, which can be differentiated with the subacute onset for scleritis, and the discomfort is mild. There is tearing, there is photophobia present, and it may affect the entire eye, but usually it's sectoral and it's unilateral when it presents normally. Management is generally supportive. However, if the patient's complaining of significant pain, then you can trial an oral NSAID. Okay, so we have another case-based scenario. A 29-year-old woman presents to ED with an acutely painful red eye. She has a past medical history of Crohn's. The pain started suddenly, approximately 4 hours ago, and she has now developed blurred vision in her left eye, along with significant photophobia. On examination, she has normal visual acuity on both eyes, and fundoscopy reveals the presence of a hypopion. So just take a moment to think about what condition that may be, especially with the presence of a hypopion. And given the likely diagnosis, irritation of which cranial nerve causes photophobia in this case? Okay, just take a moment to think about it. Okay, so photophobia is thought to be due to irritation of the trigeminal nerve in anterior uveitis because of the ciliary spasm. So that's the condition that the patient's presenting with. Uveitis in general is a term that's used to describe inflammation of the uveal tract, and that involves iritis, that involves the iris, the choroid, and the ciliary body. In this case, anterior uveitis, which is also known as iritis, refers to inflammation of the iris, and it's the most common type of uveitis. So any form of uveitis is accompanied by increased vascular permeability. In anterior uveitis, a slit lamp would show white cells circulating the aqueous humor, and it's found in the anterior chamber. So, for example, here. And protein, which leaks into the anterior chamber from the blood vessels, is picked out by its light scattering properties and in the beam of the slit lamp, and that shows up as a flare. So if you see here, this flared appearance is from the proteins, and then the cells circulating the anterior chamber can be seen here. Keratic precipitates, which you can see here, are inflammatory cells. They clump together in the endothelium of the cornea, so kind of the posterior aspect of the cornea. And if the inflammation is severe, it can kind of settle at the bottom and form a fluid line, which is called a hypopion. You might also get a posterior synechy, which synechy in Greek just means hold together, where the iris holds onto the lens and binds down to the pupil. So in terms of management, topical steroids is the main treatment and used to reduce inflammation and prevent adhesions in the eye. In posterior uveitis, systemic steroids may also be considered, or it should be considered, because in posterior uveitis, the topical steroid would not penetrate into the posterior segment. Cycloplegic mydriatic eye drops are dilators, which paralyze the ciliary body and relieve pain and prevent adhesions between the iris and the lens. So examples include cyclopentolate or atropine, both 1%. Next, we move on to microbial keratitis. Bacteria are the most common cause of infectious/microbial keratitis, and they can involve both gram-negative and gram-positive bacteria. 80% of bacterial keratitis is thought to be caused by strep or staph or Pseudomonas infections. However, the prevalence and the organisms causing the keratitis does depend on the region in which the person lives. So contact lens wear is a major risk factor for bacterial keratitis because it comes in direct contact with the eye surface, so is able to spread pathogens very easily. Symptoms would include pain, discharge, vision loss, and photophobia. Corneal ulcer is also seen in patients when they have bacterial keratitis, and it's thought to be a very classic feature. So essentially it's an open sore on the outside of the cornea. So pictures A to C show different severities, so mild, moderate, severe, whereas D to E can show the different locations in which the ulcer may form. Investigation into the type of species should be done with corneal scrapings, and a broad spectrum antibiotic should be started until the culture is identified. Cyclopegia, which we mentioned before, dilators, can be given for pain. Okay, and next is acute angle closure glaucoma. So acute angle closure glaucoma is an ocular emergency that results from a rapid increase in the intraocular pressure because of an obstruction in the outflow of the aqueous humor. This is commonly because of a blockage in the trabecular meshwork. So several factors can lead to the obstruction in acute angle closure glaucoma. However, the main predisposing factor is the structural anatomy of the anterior chamber, which leads to a shallower angle between the iris and the cornea. The main risk factors are increasing age, being female, and also East Asian or / Inuit race. And this is because of the structures of the eye for that group. Symptoms include sudden onset, severe unilateral eye pain, and this can be accompanied by a headache, nausea, and vomiting. There is blurring of the vision, there's reduced visual acuity, and you'll see a classic fixed dilated pupil. If you were to perform a slit lamp examination, it would show cupping of the optic disc, and tonometry would show a raised IOP, and that's because of the blockage in the draining system. In terms of the management, you first want to do whatever you can to reduce the intraocular pressure. So, for example, you can lie the patient flat, which may relieve pressure on the angle. You may use analgesia and antiemetics for symptom relief. With regards to the pressure itself, carbonic anhydrase inhibitors are first line, and it's usually given topically, such as acetazolamide, and that decreases the aqueous humor formation. You can use topical beta blockers, such as timolol. You can also use topical alpha-2 agonists, such as brimonidine, or both which will decrease aqueous humor formation. Or you can use topical cholinergics, such as pilocarpine, which induces pupillary constriction, which widens the angle. The kind of mainstay of treatment once the pressure is reduced is peripheral iridotomy, which is a surgical procedure. But if someone presents in primary setting and you're suspecting acute angle closure glaucoma, it would need immediately to be seen by an ophthalmologist. Okay, so there are some other differentials that I wanted to mention with regards to a red eye. So the first one is a subconjunctival hemorrhage. It's usually painless, and the mechanism is usually idiopathic. Self-resolves, don't usually need to do anything about it. Post-operative endophthalmitis, which occurs following surgery, and you'll see kind of the hypopion and the relevant kind of infective symptoms. You can also have a corneal laceration, as you can see the mark there. You could have chemical injury to the eye. The last three need urgent review by an ophthalmologist. The first one can just be dealt on a wait and watch basis. But the important thing when someone presents with a red eye is to get a clear history of the onset, because that will help differentiate a lot of conditions. The symptoms that they're presenting with, whether it's affecting their vision, and the mechanism of injury, if it is an injury. So some red flag signs and symptoms. So symptoms may include reduced visual acuity, moderate to severe pain, headache, photophobia, and pain on pupillary constriction. Signs may include ciliary injection, loss of red reflex, pupillary abnormalities, corneal defects or haze, hyphemia, which is blood in the anterior chamber, or hypopion, which is a collection of fluid in the anterior chamber. You could also inquire about the mechanism of injury if it is an injury. So it can be if it's a high velocity injury, if there's a foreign body or a penetrating lesion, or a chemical eye injury. You can refer them straight away to an ophthalmologist. Conjunctivitis within the first 28 days of life, it also requires investigating. So we'll move on to some SBAs. The first one, a 45-year-old woman presents to the GP with a 3-day history of right eye pain, redness, and blurred vision. She denies any prior similar episodes and has no significant medical history. She reports a purulent discharge upon waking. On examination, the right eye is hyperemic with a central corneal ulcer and stromal infiltrates visible on slit lamp examination. Her visual acuity is reduced to 6 out of 36 in the affected eye. So just take a moment to read the history. Okay. So, given the likely diagnosis, which of the following is the strongest risk factor? Prolonged use of topical corticosteroids, overnight wear of contact lenses, trauma with vegetable matter, contaminated use of eye makeup, or previous ocular surgery. Let's take a moment to think about what you would answer. Okay, so overnight wear of contact lenses. Wearing contact lenses overnight or other poor hygiene related to their use is the most significant risk factor for this condition because it can lead to bacterial contamination and reduced oxygenation to the cornea. This predisposes the patient to infective keratitis, which is what they had in the case. And infective keratitis is an ocular emergency, so you would need to refer them urgently. Prolonged use of topical corticosteroids is a risk factor for keratitis. However, it is not mentioned in the patient's history. Trauma with vegetable matter is more commonly associated with fungal keratitis. Use of contaminated eye makeup can lead to bacterial infection. However, it's less likely to cause corneal ulceration without contact lens wear. Previous ocular surgery is a risk factor, however, is not as strong as contact lens use overnight. So, second SBA. A 26-year-old man presents to eye casualty with an acutely painful right eye. His symptoms have developed over past 3 hours and he is now describing increasing blurred vision in his right eye. His visual acuity is normal. Fundoscopy reveals the presence of a hypopion. Okay, so given the likely diagnosis, what is the most appropriate management? Take some time to think about the answer. So corticosteroids. Iritis or anterior uveitis classically causes an acutely painful red eye associated with photophobia and blurred vision. It's likely here given the pain, photophobia, and presence of a hypopion on examination. Steroids are used to reduce inflammation and prevent adhesions the eye, and it can be given topically, orally, or IV, depending on the severity. Referral to an optometrist is required for patients with suspected cataracts rather than iritis. Ophthalmology referral is advised if people have presented with suspected iritis/anterior uveitis. Acetazolamide is a carbonic anhydrase inhibitor, and it's used in the management of glaucoma rather than iritis. And cyclophosphamide would be incorrect because cyclopentalate rather than cyclophosphamide is a cycloplegic mydriatic drug used in the management of iritis. Cycloplegic mydriatic drugs are used to paralyze the ciliary body to relieve pain and prevent adhesions between the iris and the lens. Adenosine 1% would also be incorrect because atropine rather than adenosine is another cycloplegic mydriatic drug used in the management of iritis. Okay, third SBA. A 34-year-old woman presents to GP with a 2-week history of redness and discomfort in her right eye. She describes the discomfort as a gritty sensation rather than pain and reports no vision changes. The redness is localized to the right eye with no discharge. Her medical history is unremarkable with no known drug allergies or autoimmune conditions. On examination, the right eye is diffusely red and dilated vessels on the episcleral layer, as seen on the image. Visual acuity is normal and there's no pupillary abnormality. Slit lamp examination reveals no anterior chamber flare, and if application of phenylephrine drops results in blanching of the redness. What is the most likely diagnosis? So take a moment to think about it. So episcleritis is the correct answer. Episcleral inflammation or episcleritis, patient presents with mild discomfort and redness that blanches with phenylephrine, so it's consistent with the patient's symptoms and findings. Scleritis, usually you'd have severe eye pain, it doesn't blanch, and that's how you'd distinguish it. Acute angle closure glaucoma would present with completely different symptoms. You'd have severe pain, reduced visual acuity, mid-dilated non-reactive pupil, and those are not reported by the patient. Uveitis would show anterior chamber flare or cells on slit lamp examination, which wasn't present in this patient. And corneal ulcer would have much more severe pain, photophobia. They'd also have decreased visual acuity and a visible corneal defect on examination. Final SBA. An 11-year-old child presents to the GP with red, watery eye. There is slight blurring of the vision, however, she reports no pain. Her sister had similar symptoms a week ago. There are no pupillary changes, and fundoscopy reveals no retinal abnormalities. The appearance of the lower lid is shown. So just take a moment to look at the lower lid and think about what this might be. Okay, and given the likely diagnosis, what is the recommended management? So the recommended management in this case is self-care and reassure, because the presentation is in line with viral conjunctivitis, given the infectious cause. They got it from their sister, the follicles being present, and the watery discharge. So usually it would resolve in 1 to 2 weeks, so only supportive management is needed. Chloramphenicol eye drops would be incorrect because it's used in bacterial conjunctivitis. Because the discharge is watery, it's more likely to be viral. So we're not suspecting any bacterial cause, so antibiotics would not be appropriate in this case. Topical antihistamines, this is considered an allergic conjunctivitis, but again, given the infective nature of the spread, the diagnosis is more likely to be viral. Urgent ophthalmology referral would not be appropriate in this case because conjunctivitis is not a vision-threatening condition, and it can be resolved at home. Oral NSAIDs are typically used in scleritis to manage uveal inflammation, and this would not be required in viral conjunctivitis because it does not affect the uvea. Okay, so that is the end of the webinar. Feel free to scan the QR code for feedback and also to receive a handout of everything that was discussed today. Thank you for attending.